So welcome to HAE Australasia's question and answer session with Professor Katelaris. Given the current pandemic situation we're in, we at HAE Australasia wanted to give you some local answers to the situation and to help you navigate through all of the unknowns with COVID-19. To walk us through this and to answer our questions, we're very fortunate to have Professor Katelaris joining us on the video today. Dr. Katelaris will also be answering questions on some other topics like current and new treatment options, clinical trials, and also announcing an exciting new project that we have with HAE Australasia. For those who haven't had the opportunity and the pleasure to meet Dr. Katelaris, would you mind introducing yourself, please?
Certainly. Hi, Fiona. So, as you've heard, my name is Connie Katelaris. I'm Professor of Immunology and Allergy at Western Sydney University and Head of Unit at Campbelltown Hospital, a teaching hospital of the university. I also have a private practice in the western suburbs of Sydney in Westmead. I have a large number of patients with HAE that I look after, as I've had a very long-standing clinical interest in HAE dating back to the 1980s. I've been a very active clinical researcher in this field, having done or participated at least in some of the early clinical trials with some of the medications that many of you are now using. We're also participating in some of the international registries, and we have our own investigator-led projects up and running. So it takes up a good bit of my time.
So thank you, Dr. Katelaris, for joining us. Let's go straight into the coronavirus. How does it and how can it affect patients with HAE?
The first thing I'd say is that it's important to understand that HAE is not a classical immunodeficiency. So in fact, people who have HAE aren't at greater risk of becoming infected or having a more severe infection unless they carry one of those other so-called comorbidities or other factors that we have come to recognise as being risk factors. So in other words, older people, particularly those over 60, people who have diabetes, hypertension, chronic respiratory disease, all things unrelated to their HAE, but they may well have other medical problems. So those people carry the risk of those particular problems, but HAE does not make you more susceptible to actually catching the virus. However, if someone with HAE does contract the virus, then we have a couple of things to consider. The first is we know that viral infections are a significant trigger for having acute attacks for many people with HAE, not for all, but for many. So it's possible that there may be more HAE attacks associated with a viral illness. The second thing is for the small percentage that go on to have severe or critical disease and who may need intubation, then this is of great significance to those who have HAE because the airway has to be managed, prophylaxis needs to be used acutely and so on. So to summarise, no greater risk than the general population unless you carry those other general population risk factors. But if you get the virus, there are other considerations that we need to take into account.
Thank you. It's good to know that we're sort of not any more susceptible of catching it than any others, other than, you know, for the people that you said would be more susceptible. So if people are feeling anxious about, you know, getting coronavirus with HAE, what should they do to try and prevent that?
So the advice for people with HAE is exactly the same as it is for the general population, and hopefully everyone has heard this message many, many times over the last 3 to 4 months. That is practicing good standard hygiene precautions. Washing your hands thoroughly, whether that be with soap and water, taking enough time to wash both the front and the back of the hands, or using an approved sanitizer. Keeping your distance from people, you know, the 4 square metre rule, 1.5 metres from the next person. Covering your mouth when you're coughing and sneezing and staying away from people who do that. Staying away from anyone known to be unwell, and obviously limiting your contact with a large number of people. So it is all the standard precautions that you've heard people from the Department of Health say over and over on nightly news.
So given we talked about, people over 60 and others that may be susceptible, what about pregnancy in women? Is that something that, pregnant women really need to be looking out for as well and being careful of?
So this is a question that obviously every pregnant woman worries about. So the first thing to say is that anything we know about pregnancy and COVID-19 infection comes from relatively extremely small numbers of people who have actually been infected while pregnant. So to give you some idea, in the USA, we have 40 to 50,000 deaths from COVID-19, and we know there are over 2 million confirmed cases of COVID-19 infection. There have been publications of about 500 pregnant women who have contracted COVID-19 in that particular country scenario. In Australia, as you know, our figures are far, far fewer, so it's very difficult to draw any conclusions. So if we look at the UK and the USA, where we have numbers of a few hundred, but not many compared with the great number of COVID-infected individuals, we can say a few things about pregnancy. We don't believe that pregnant women are more at risk of contracting COVID-19 than non-pregnant women. While the UK has made a statement that pregnant women should be regarded as in the vulnerable group, they base that on information from influenza. And we know that influenza is a very different infection. And we know that pregnant women are more susceptible to more severe influenza infections. But that has not been borne out for the coronavirus infection. So we don't believe they're at greater risk of severe illness, and the vast majority of pregnant women who have contracted the virus have had a mild to moderate infection. So to put a few statistics around that, in the USA of nearly 500 pregnant women, about 15% of them would be regarded as having had a severe infection, and just 1% critical. Now that's no different to the proportions in the general population. We don't believe, because there's no evidence to suggest it, that miscarriage in early pregnancy is any more likely in a pregnant woman than a non-pregnant woman. We know that there have been a few earlier than term births in women who have contracted the virus in late pregnancy in the third trimester. And we're talking about 36, 37, 38 weeks, not terribly premature. There's been exceptionally small numbers of infants born to women with COVID-19 showing evidence of viral infection. So we believe what we call the vertical transmission from mother to baby is extremely low. There's no evidence of a problem with breastfeeding. So women who have had COVID-19 or have COVID-19 are still encouraged to breastfeed. There have been more than the usual number of cesarean births, but that's probably for reasons of taking precautions. So again, the information for pregnant women is much the same as the general population. Practice all those safe precautions, hand washing, keeping your distance, staying home if unwell, staying right away from unwell people. And I think most pregnant women are going to be very cautious, along the lines that I've just outlined. But it is reassuring to know that they don't run a large risk or even a greater risk than the normal population. The group that appears to be a little bit more at risk are women of an older age. Obviously, they're still childbearing, but older pregnant women, and particularly women with diabetes. And we know that diabetes is a risk factor across the board.
Thank you. That was a really good explanation, and I'm sure that with that great information, that does answer quite a lot of questions for everybody. This next question came from one of our parents, and it's there have been reports about children suffering from rare side effects from COVID-19 similar to Kawasaki disease with symptoms of severe inflammation. Would children with HAE be at greater risk of suffering from these side effects?
Okay, the simple answer to that is no. And I think to put in context what this emerging disease entity is, I need to give a little bit of an explanation, because not many people know about Kawasaki's disease. It is a very rare pediatric condition that in its classic form, as we know, Kawasaki's disease, is seen almost exclusively in children who are 5 years or younger, okay? And it's most likely seen in the context of following a viral infection, and it appears to be a systemic inflammatory syndrome where, if you like, the immune system goes into overdrive after or during a viral infection. And that sort of activates the immune system that becomes inappropriately active and can cause a lot of very severe symptoms. Now, we do have very good treatment for it, and the use of intravenous immunoglobulin has really revolutionized the management of young children with Kawasaki's disease, and that treatment is readily available and safe in this country. The biggest risk with classical Kawasaki's is heart damage, and these children can end up with permanent heart damage if they are not diagnosed and treated. But as I say, there's a high recognition rate in the major children's hospitals, and early treatment gives these children an excellent prognosis. So that's classic Kawasaki's. What has been noted in the USA and in Italy, because of course these countries have had enormous numbers of COVID infection, is that a number of children, and interestingly teenagers, who have COVID-19 in these hotspots are coming through with a condition, again, that's a systemic inflammatory condition, and it's actually been given a novel name of multisystem inflammatory syndrome, because while it has similarities to classic Kawasaki's, there are differences. One of the major differences is, as I said, Kawasaki's is not seen in children over the age of 5, whereas this Kawasaki-like presentation with COVID is seen in older children and teenagers as well. And these children present with high fevers and this sort of immune activation syndrome. And they can have significant heart damage. From the cases that have been reported, they probably don't have quite as good a response to the intravenous immunoglobulin as children with classic Kawasaki's without COVID. So it's an emerging area. We still don't have a lot of information because it remains rare. I mean, compared to all the children and teenagers that have had COVID infection, this is a very small proportion. But of course, it's good to know about it. It's good to look out for it. It has its own symptom complex. And these children will be in hospital. They will be very ill. They may go into shock. So if anyone has a child or a young person who's at home with COVID infection, who starts to get worse and starts to spike a high fever, then they have to be in contact with the health authorities immediately, as these children need to be in hospital. But children with HAE are not at greater risk as far as we know. In fact, I personally don't know of any people with HAE with COVID infection to date.
Thank you for that detailed answer. So with regards to coronavirus and the treatments that we use, Berinert IV and Berinert subcutaneous, will these treatments remain safe in the future with blood donations during this time?
Yeah, now that's a very good question. I mean, it's an important one for people to have confidence about using their blood-derived products, which for us in Australia is the Berinert product. There's no evidence of transfer through blood. Remember that all those health precautions that are put in place to help us prevent getting COVID are due to the fact that this virus is airborne droplet transmission, okay, and close contact transmission, not a blood-borne disease. So blood transfusion goes ahead with no problems. There's been no case worldwide of transmission via blood transfusion, which is a far more common blood product than C1 inhibitor concentrate in its usage. And people may still be blood donors, even if they've had COVID-19, providing they have 3 negative tests, and that usually takes about 28 to 30 days. So we have all confidence that there's no transmission through blood-derived products such as intravenous immunoglobulin and C1 inhibitor concentrate like Behring.
That's good to know. I'm going to move on to some current treatments, and as we know, danazol is no longer available in our country and also I think in New Zealand. And given that we have a good number of patients still using danazol and their stocks are starting to run out, what should the patients be doing now?
So I see this, everybody says no crisis should be let pass without seeing it as an opportunity. And to me, the crisis around the lack of ease of access to danazol is a great opportunity for people with HAE to have their HAE reviewed. And I must say, even in my own experience over the last month, I've been contacted by patients that I may have seen a decade ago who have not had any contact with me because they've been happily going along and getting their danazol from their GP and being happy on it. So it's an opportunity for review of where you're up to with your HAE and your attack rate at this time. So just to backtrack a bit about the supply, the companies that supplied Australia who brought danazol in here have stopped manufacturing. So you're right about the Australian supply. There are overseas manufacturers where we can access a danazol product, but it is a rigmarole and you will be paying a lot more for it than you've ever paid for that drug, which is a relatively cheap drug in Australia. So we have two sources of being able to get it. However, your doctor needs to apply to the TGA for a particular form called an SAS form to allow the importation of a product that is not available in Australia. And they are, they're expensive. One manufacturer supplies 100 milligram tablets in a bottle of 60 for $145. So that would, allow the average person on 200 milligrams daily, 1 month's supply. Okay. And another manufacturer, 200 milligram tablets, will supply 56 tablets for the mere price of $265. So there's a great step up in cost, and there is a bit of a delay because your doctor will have to get the TGA form. So while there's a possibility of continuation, there are other things I think people should be doing. The first thing is, as your supplies are running low, it's really important to start tapering the danazol dose. Don't wait until you're on the last tablet and just stop abruptly. We know from a lot of experience that people who stop danazol abruptly are likely to have an increase in attack rate, sort of like a rebound. So if you say, well, I've still got a bottle of 30 tablets left and I'm usually on 1 a day, my advice is to step down to 1 every 2nd day and then 1 every 3rd day until your supply runs out. But long before that time, you should be in contact with your specialist. Even if you have not seen him or her for a long time, at least book in for a phone consultation. Second thing I would say is it's time for review. I think it's reasonable as long as you have your acute management treatment on hand, and what I'm talking about here is either your icatibant, Firazyr injections, or for the few people who don't respond well to Firazyr, IV Berinert on hand. So your usual acute management treatment, you should make sure you've got at least 2 doses on your person at all times, because it's possible as you wean off the danazol that you will start to notice more attacks. And so you should be able to treat that. So you should have scripts for enough repeats and physically have 2 doses. You should let your specialist know so that you can have a review fairly promptly. Start keeping a diary of your attacks, because if you find off danazol your attack rate is very frequent, then you may well qualify for a better and more modern form of prophylaxis. If you do not, this is a discussion to be had with your specialist about whether you should access the danazol from overseas or how you're going to manage it. But any person with HAE can manage their HAE in the short term with acute on-demand treatment. So to me, that's really important that you have adequate supplies, adequate repeats, that your pharmacist knows to keep some for you, and to start keeping a diary so you can see where you're at. So I think it's time for review. We know that danazol has its problems, and it's a good time to have all that reviewed.
Thank you. So we talked there about Behring. So now that subcutaneous Behring is available, how can a patient change from the IV Behring over to subcutaneous?
Okay, so patients who qualify for Behring prophylaxis can use either IV or subcutaneous. The qualification is the same. It's my opinion that the majority of people who are currently receiving Behring IV will want to change to subQ. It is easier. There's less stuff to carry around if you wish to travel with it. And, you know, for patients who are starting to have problems with intravenous access, putting the needle into veins that have been punctured many times before, it's a great solution. But medically, the biggest reason, from my point of view, is we know that Behring subQ is more successfully controlling HAE attacks. And the reason for that is what we call the pharmacokinetics of this. When you have it subcutaneously, there is a much better and more linear absorption and maintenance level. So instead of getting a zigzag of you have a hit of IV, then it decays, and then you get another hit, and then it decays, and you're up and down, and your levels may fall quite low, and you're a bit more vulnerable in between your infusions. With Behring subcutaneous, you get a more even distribution in the blood, and so you get greater protection. Now, while there haven't been what we call head-to-head comparisons in clinical trial settings of IV and subcutaneous, if you look at the results of the phase 3 clinical trials using one or the other, you have a lower attack rate on the subcutaneous overall. So for those who don't have perfect control on IV, they should move to subcut. For those who are having problems with venous access, then they should move to subcut. But having said that, I have a patient or two who are perfectly happy on their IV, and at this stage don't want to change. So if you have 0 attacks and you're managing things, there's no great impetus to change. But for those who have the problems I've defined, then they should have the opportunity of trying Behring subcutaneous. For any patients that I see from now on, now that we have the subcutaneous available, if they meet the criteria for prophylaxis, I will be going straight to subcutaneous. And I think Behring IV will be reserved more and more for acute management for those who can't or do not have a good response from Firazyr, or who need short-term prophylaxis.
You talked about fitting the criteria, which is quite strict at this point. Could you please explain what that criteria is and the best way for patients to make sure that they can fit that criteria or do fit that criteria, and then you know, speaking to their specialist about changing over?
Mm-hmm. It's very important to understand this, because we as doctors are very much bound to these criteria. We cannot prescribe outside the criteria. We are talking about extremely expensive products, so there is the onus on us to be responsible in its use. Unfortunately, in Australia, the only criteria that is taken into account is number of attacks. Now, while we write in our guidelines that the way we decide on prophylaxis should be a lot more encompassing than a mere numerical attack number, that's not the case. So at the present time, with the limitations we live with, it has to be 8 or more attacks a month for someone to qualify for Behring prophylaxis. So my advice is to ensure that you keep a diary. And look, I don't mind how you do that. You write it in your usual day-by-day diary. You keep a piece of paper that you write on. You put it in an app or on some other app in your phone. Any way that there is a record of your attacks. And you shouldn't be shy about what constitutes an attack. If it's a small swelling, write it down. If it's a large swelling, write it down. If it's abdominal pain plus a peripheral swelling, write them both down. So it's it's the way one counts, isn't it? And you can't count if you don't have a record. So it's important that everything that constitutes an attack is written down, and then you have a discussion with your doctor about how this is impinging on your well-being, on your ability to work or go to school or just live life normally. That's what you should do. And, you know, if you are having very frequent attacks and you qualify, then you can look forward to a much better quality of life. It is my hope and wish that one day we liberalise those extremely rigid criteria, but that's not what we live under at the moment. So to comply, I and other specialists looking after patients with HAE need that written or that record, whichever way you keep it.
It's also important to note that those guidelines are for us here in Australia. In New Zealand, they're unfortunately they don't have any prophylaxis, so this is a totally different ball game that we're playing with over there. But it's important to note that the information we just supplied there was for Australian patients.
Yes.
So with regards to Firazyr, and this is something that's been indicated recently for children, and New Zealand did have this quite a while before we did. Can you please explain what the difference is between the doses and anything that parents should be aware of?
So this has been a great advance as far as I'm concerned. So Firazyr is now indicated for children down to 2 years. So from 2 years and above, we can use Firazyr for acute attacks. And given that we know that attacks in children under 2 years are very rare, this is great because it's going to cover the majority of our children. For those under 2 years, we still have Berinert for acute attacks, which are few and far between, and in fact a very rare occurrence. So there won't be any specific new syringe for Firazyr for the paediatric age group, and it is a weight-based dosing. So it's divided into 3 doses for children. And as you know, for adults, it's 30 milligrams in a 3 ml syringe. So it's either 1, 2 or 3 mils, depending on the child's weight. Basically, any child over 40 kilograms can have the full dose. Under that, you either give 1 mil or 2 mil. And the company has made a little gauging device that you can insert to draw out either 1 mil or 2 mil. Now, if in a panic or whatever it goes wrong, we know it's not dangerous to give the child more than that, but it's 1 mil and then 2 mils and 3 mils, and it's written on the ASCIA HAE treatment chart for doctors to see as well. And, you know, parents of young children should be given very good instruction and a demonstration of how to do it, and that's what we do here in our clinic.
We're also very lucky to have some new treatments on the horizon, and our patients and family members in Australia will know how much I've been sending out emails and posting things on Facebook about the new treatment lanadelumab, which is going through the PBAC at the moment. But there's that and some other treatments coming through. Are you able to explain what they are, please? Sure.
So I think, like everything with HAE, let's talk about acute management and prophylaxis. Okay. So there are, I mean, HAE is just a very exciting field to be in at the present time, because the so-called pipeline, the drugs that are in development and in clinical trial, it's amazing what's coming through, and so many drugs for such a rare disease. So it really is an area that has captured the research imagination as we've understood more and more about the biochemical pathways that drive angioedema attacks. So for acute attacks, what's coming is, people will be very happy to hear about this, is an oral treatment with a drug that's known as a kallikrein inhibitor. Now, we here at Campbelltown were one of only 2 centres in Australia that took part in the clinical trial for this, and it had a code name of BCX. It's now named, and it's a rather difficult name. It's called Beroltrelstat. I hope it'll have an easier name, but it's a tablet. It's an oral formulation, and it's proven to be highly effective for acute treatment. Interestingly, it's also been shown to be highly effective as prophylaxis when it's taken on a daily basis. So for acute treatment, you take it at an early onset of an attack, and it works. I mean, if you wait until you're totally swollen, it's not going to be so effective. But if you take it within the first few hours of an attack, it's very effective acutely. But it's also been trialled as a once daily tablet for prophylaxis, and again, has been shown to be very effective. To be fair, the data suggests it's probably not quite as effective as something like Berinert SC or lanadelumab, but it is still very effective, and being an oral treatment has great advantage for many people who find injections difficult. So that's not here in Australia yet, and people like me still can't get our hands on it for early access, but it's coming. And for prophylaxis, it has been approved by the FDA, so it's in the pipeline. One would hope that it's going to be priced more attractively than our injected treatments, but I don't have any more information about that. For prophylaxis, excuse me, you've mentioned lanadelumab, and that's the big new hope that's almost within our grasp. So this is marketed by the name of Takhzyro. It is already registered in Australia, but it's not yet reimbursed. It has been to the PBAC once and knocked back, and it goes again next month in July. So I think you've got until about the 20th of June to write a submission. It's closed, has it? I'm getting a nod from Fiona. Yes, it's closed. So I and my colleagues here, and I've exhorted most of my patients to put in submissions, and I know Fiona's done that on behalf of HAE Australia and as a personal response as well. So let's hope enough people have made strong arguments for it to be reimbursed in this country. It also will be very expensive to the government, so I don't have any expectation that it will have any easier access than the present Berinert SC. So I think it's probably going to be pitched at about 8 attacks a month before you qualify. But the beauty of lanadelumab is it's once every 2 weeks instead of twice weekly. It's a much easier injection. It's not a blood product. So, and it's highly effective. All the clinical trial data suggests great effectiveness, and the side effect profile is very attractive in that there's been very few problems seen with it. So I think for those who qualify for it, it's going to be a big bonus. And that I'm hoping we have a good outcome from the July meeting. If we say it does have approval at the July meeting, it can take somewhere between 6 to 9 months before it's actually listed on the PBS. So don't go ringing your doctor the next day you hear the news that it's been approved by the PBAC, because we still won't have access for many weeks once it is approved by the PBAC. But that's the next step. So that's very exciting. I've mentioned the BioCris once a day tablet, but again, not here yet. The CSL have a monoclonal antibody, which is an injection, and it's now being named as garadacimab. They all have very difficult names. We were involved with one of the earliest studies with this. It's a factor 12A monoclonal antibody, so it works differently to lanadelumab and the BioCris tablet, which are kallikrein inhibitors. And we don't need to go into the biochemistry, but it works on a different aspect of the pathway that's affected in HAE. And again, the early studies have been very promising, and CSL will now be entering into larger phase 3 studies with that, and we are looking at participating in that. Another company called KalVista has their own oral kallikrein inhibitor tablet that's in clinical trials. So, as I said, there are many promising molecules around. But ultimately, what I want, and I'm sure what all of you want, is a cure. And I think the really exciting horizon stuff is gene replacement and gene editing techniques, which again are really advancing at a great pace. And some of these techniques are now being employed for other very rare genetic diseases. And there's no reason why that technology cannot be translated to HAE. And there are 1 or 2 companies in the States that are actually looking at this, and I've had conversations with them indicating our great interest in participating if and when they get it to that clinical trial stage. So that's a bit further off, but really for the next generation, to me, that's a real possibility. And of course, that is aiming at cure.
So how often should a patient see their specialist? And hearing about all of these new treatments, when is the best time to start talking about those? I know that a lot of them are way off, but you know, is it a good idea for patients to start talking about these things in case the physician doesn't know about them yet?
Yes, so through places like HAE Australasia and HAEI, if patients access this information, they have really good information about what's in the pipeline. But obviously with HAEI, there's a very strong bent towards the North American position. So it's important that you keep it in the Australian context, and that's what HAE Australasia does, of course. If you are seeing a specialist who looks after a lot of HAE patients, they will be very versed in what's coming, what's on the horizon, and so on. But you won't know about it unless you chat with them. So to come back to your question about how often should you be reviewed? Now, that's a highly individual thing. My personal practice with the many HAE patients I have is I like to keep in touch at least 6 monthly. And that doesn't necessarily mean face-to-face. It can be via telehealth. And now, again, one of the opportunities that's come out of the COVID crisis is the government expanding our ability to access telehealth for people who may live in the same city as the doctor. And I think for a lot of HAE patients, telehealth is perfectly adequate because usually when you come for your appointment, there's nothing to see or to examine. It's all on history, and one can email through a diary. So telehealth is a very real possibility if you hate going for appointments. Other patients like a face-to-face visit to have a discussion with their specialist. I think it is important that you do set up some frequency of review, at least 12 monthly, even if you're not having very frequent attacks, because A, you may learn about new possibilities, you may learn about clinical trials you might be interested in, you can have your medications reviewed, you can ensure that your treatment plan, doctor's letter, and so on are up to date, and you can ensure that you have adequate repeats of scripts. For those who have frequent attacks, it's really important to see if you qualify for good prophylaxis, to gauge prophylaxis and how effective it is to iron out any problems. And for those who will persist with a danazole product, I think you need 6 monthly reviews to look at your lipid profile, the fats in the blood, to check your liver, and so on. So there are many reasons to be reviewed. If you see a change in attack rate or in severity of attacks, I think that's a time where you should trigger an appointment so that you and your doctor can talk through what might be going on. If you know you're coming up to a stressful period in your life, you know, like HAC exams or a divorce or anything like that, that you can see, good time to talk about the possibility of prophylaxis to help you through that sort of trauma or stressful situations. So I think there are routine visits that I think should at least be once every 12 months. And I think there should be visits that are triggered if there's been a change in your condition or a change in your medication so that you can gauge its effectiveness. Now, that's a personal view. Other doctors may differ slightly, but I've given you my view as someone who manages a good number of HAE patients.
Thank you. And you've actually answered a lot more of my questions that I had, so you've saved me some time. So one of the exciting things that we have going on is something that's brand new. And this sort of came about by us talking and you coming up with a great idea, and it's offering a support service for patients. Can you explain what this support service is all about and who can use it and what services that are available for patients and their family members?
Okay, so for those of you who are engaged with HAEI and with HAE Australasia, you're probably aware that in some parts of the world, there are centres that are called Centres of Excellence in HAE, and I'd point to the one that Mark Rydell runs in San Diego and so on. And in the UK, there are Centres of Excellence. So some countries have this as a model of care for patients with conditions such as HAE. Australia doesn't have that model of care, and to have a physical centre for a country such as ours or for New Zealand, where the numbers of patients are very low in proportion, is just not a viable option. In Australia in particular, no patient is going to be interested in travelling to one centre when they live, thousands of kilometres away. So my idea is to set up, if you like, a virtual centre of excellence. So this will be purely via telehealth. And again, this opportunity has now become a lot more mature since the COVID crisis, because many of us have learnt to use telehealth in a much better way. Hospitals have learnt to embrace it where they weren't before. The online platforms for video conferencing are improving all the time, so that we can sit remotely but look as though we're almost in the same room. So it gives you that personal face-to-face contact, or if you don't have the technology to participate that way, at least by phone as a telephone consult. So the idea would be to have the virtual centre open at least to start, perhaps once a month. We might find we don't need it that frequently, but we will start once a month. And there will be a specialist nurse and a specialist doctor on hand. It's not necessarily going to be a treatment centre, although patients that belong to our clinic may want to use it that way, and we'd be happy to do that. But it would be open to anyone with HAE if they need to access advice, if they have any difficulties, if they just want some more information, or if they want things sent out to them. We would be able to put them in touch with HAE Australasia if they don't already know about that. We have the materials from HAE Australasia which we can disseminate. So it would be a point of contact that would be different from your treating specialist if you felt you wanted that. But we will also incorporate our treatment centre into it as well. For those of our patients who live remotely, who we actually deal with more informally now, it'll be formalised and they'll have an appointment. So when it's up and running, and it's not yet, it will be in the sort of last quarter of the year. I mean, COVID has set us back quite considerably with a number of these initiatives, but hopefully it will be up and running in the last quarter of the year. And we will disseminate that information through HAE Australasia. And there will be an email where you will ask for an appointment, and our nurse running the virtual clinic will let you know. You'll be given a time, and then you'll be hooked up on the day. So it means you could go to work and just slip out and have that time, or if you're at home, stop what you're doing and just have that time with the specialist and the nurse. So it might be procedural things, it might be information, it might be checking facts, it could be any reason that you might want to have that contact.
So for patients who need access now until the virtual centre is up and running, is there a facility or a service that they can access at this point until that is in full swing?
Yes, we're hoping to have, if you like to call it, a light version next month. So COVID has changed a lot of people's plans, but the health system is opening up and is now amenable to novel approaches. So at this stage, and we'll confirm that through HAE Australasia in the newsletter, we'd be hoping that the last Friday of July would be our first light version virtual clinic.
That's great. I'm sure it'll be very worthwhile for a lot of patients that can't access their physician straight away or need some help, or and we also talked about the possibility of pointing people in the direction of a psychologist if they need it, or a nurse to help with finding veins and that sort of thing. So it's going to be a really worthwhile and, you know, purposeful centre or support service that patients can use, and even, you know, family members can phone up and ask questions if they have them. But we have had in the past, you know, where patients have gone to see their doctors and aren't quite sure about an answer that they've been given or what they can do, and they could use the service for that as well.
Yes, that's true. I'll just say a word of caution about family members. Obviously, a centre like this, it will be general information, and we do have to respect privacy. So if the person with HAE is present, there's no problems. But if, say, a spouse or a parent wants to ring up and ask questions specifically to the patient, we need consent for that. But by all means, for general educational things, it will be a service that I think a lot of families will find useful.
Excellent. Well, that brings us to the end of this video. I want to thank you so much for your time. As always, you always give us extra, and your knowledge is beyond anything else. We hope to be able to do more videos in the future when there's, you know, more things that arise, and we will definitely send out some more information about the support services. But thank you again for your time, and we hope everybody enjoys the information that was given on the video. And if you have any other questions, please feel free to send them through to us. Also, the information that we talked about today will be put into a form and accessible on our website and also through our Facebook page. Thank you for joining us.
It's a pleasure, Fiona. Thank you.